Let's talk about hereditary spherocytosis. Spherocytosis, abbreviated as HS. So, it is of two different types. It can be autosomal dominant or it can be autosomal recessive. So, it can be in two different forms, AD and AR. AD is less severe, AR is again more severe. More severe form is AR. We will focus more on AD because it is much more common and homozygous condition is seen in this case, and heterozygous condition will be in AR, which is again more and more severe. For percentage, AD is roughly around 75%, and the rest of them is AR, which is more severe in the cases of heterozygous condition. Now, let's consider a form of AD because both of this condition, AD and AR, they are presented as almost similar. Now, HS is overall an RBC disorder. So main target is RBC. Now this disorder primarily happened to the RBCs, and where the RBC cell membrane defects occur, and these defects are usually happening to the RBC because of multiple genes which are involved in it, which code for different types of proteins which are integrated in the cell membrane, and because of this different configurational changes occur and ultimately leading to the disorder formation. Now, because of these changes, so RBC cell membrane defect occur, right? This will eventually lead to altered or defective proteins. This ultimately changes the shape of RBC into spheroid. Okay, and because of this spheroid shape, the normal functioning of the RBCs and the normal movement within the RBC within the body get changed, and because of this trapping of RBC increases and ultimately it lead to death of RBC. For epidemiological data, it is more common in northern part of Europe, Scandinavian countries, and roughly about 1 in 5,000 people are affected. Now we know that RBCs are usually biconcave structure, right? And we can look at it into different views, basal views, side views. So it is biconcave. So it is biconcave and flexible. It has potential to change its feature while moving through the narrow zone. And in this disease, so this was the normal condition. In the HS, the overall shape of this RBCs changes and a sphere form, and this is called as HS. Now, some features of HS, the features of RBCs in HS, that is, overall size will be smaller, shape will be spheroid. It will become more and more rigid and less flexible, and fragility will increase. So these are some important features of RBCs. of HS features. Okay, now for the um, skeleton of the RBCs have different types of proteins. Now this is the main cytoskeleton of the RBC's cell membrane. There are different types of proteins involved in it which maintain the integrity of the RBCs so that it can be a biconcave and a flexible shape in nature. These are maintained by different aspects of proteins. Now these are mainly the band proteins, that is band 3, which mainly take part in anion exchange of chloride and bicarb. Then there can be protein 4.2, 4.1, 4.2, 4.1, and there are different types of 4 points. Okay, there can be 4.9 and so and so. Next can be the glycoprotein, glucose and protein, glycoprotein. There's a lipid bilayer itself. Then there can be spectrins of two different types, alpha and beta. Then there can be ankyrin, then actin, myosin, and so and so. There are so many. The main important ones that we need to remember for future is at least 4 main types of protein defects are seen. So first and the most common one is the ankyrin. Ankyrin. So ankyrin, this one. Then next is spectrin. Now spectrin are 2 different types, the alpha spectrin and the beta spectrin, and alpha and beta both are twisted in a helical form like this. Okay, so it is of 2 different types, alpha spectrin and beta spectrin. Good. The third is the band 3. So these are the band 3, these, and these band 3 takes part in the exchange chloride and bicarb. So band 3 and band 4.2, these are the least you should remember for the spherocytosis. Now there are defects in these 4 different types of protein. So their location for the ankyrin is it is chromosome number 8p11, that will code for ANK gene. ANK gene. For alpha spectrin it is 1q22 and q23, 2 parts, and they code for SPTA, spectrin alpha, SPT spectrin alpha gene. For the spectrin beta it is 14q23, and guess what, it is SPTA spectrin beta or B gene. For band 3 it is 17q21, and it is the SLC4A1 gene. No need to remember the gene name, just remember the protein, all these important proteins, and if you can remember the chromosome, that will be better. And lastly for the band 4.2 it is 15q21, and the gene is again not so important, EPB42 gene. So 4.2, this is the 4.2. This is the spectrin alpha and this is the beta spectrin. Then there are also additional one, actin, tropomyosin, adenosine, so on. So there are so many. But just remember these four important ones. Okay, now let's see what is actually happening. So all of these important proteins are arranged in such a way to make RBCs, which give the property of being flexible and biconcave in nature. Now, there was mutation, so diverse mutation of different types of genes located on different chromosome happen, and because of this, faulty proteins are formed. So ultimately, in this case, normally the lifespan of RBC is how much? 120 days. That is 4 months. In the case of HS, it gets reduced drastically, and the lifespan remains about 10 to 20 days. That is half month. Good. Now let's see what is actually happening. Now, because of this faulty proteins, in the initial days of these RBCs, everything still remains okayish, but slowly damage occur. So let's try to understand that. Okay. So initially RBC has normal structure, or at least we can just say it is formed completely normally. But with age of RBC, the lipid bilayer destabilized. And how it is destabilized? Because of this faulty proteins. And which type of proteins there are? They are the membrane cytoskeletal protein, right? And because of this faulty, they cannot withstand the overall integrity of the cell, and because of this they fall off as fragments within the vesicles. Now let's see what is going on. Let's see, this is the normal RBC, and it has a lipid bilayer. Okay, so this is a lipid bilayer. Now let's suppose this part is faulty, this part is also faulty, this part is faulty, and this part is faulty. With age, so initially it was normal, then slowly faulty proteins start to accumulate within the cell, and the cell will recognize it and try to eliminate it. Okay, the cell will try to eliminate it, and it will be eliminated in the form of vesicles. Okay, so this is the normal RBC, and these fragments will start to form in the form of vesicles. So outpouching will start to happen, and ultimately it will shed off from the normal membrane of the RBC. Okay, this is called as vesiculation. A very important step of pathophysiology. Now, ultimately, because a part of cell membrane is lost, so overall size will be decreased. Okay, and all the defective part is gone. However, these faulty proteins will keep on again and again forming within the cell, and it will keep on eliminated in the form of fragments. So this was one fragment, defective fragment of the cell membrane. This was another, this was another, and this was another, and ultimately a sphere or a spheroid is formed. Okay, and how this happened? So we can understand is that it happened because of a loss of membrane. So loss of membrane to cytoplasm, and because of this it forces the cell to assume the smallest possible diameter. Overall possible diameter for given volume, that is a sphere. Okay, so this happens, and ultimately overall the size will be decreased because fragments, right, these are the fragments which are actually lost from the cell membrane. Right, now let's see what will happen. Now because the structural integrity is lost and our beloved RBCs is no more biconcave, it is more of a sphere, and it is less or almost no flexibility is left within it, less flexibility. Now what will happen in that? Now because of it, of all these important features, okay, it got small, spherical, rigid, and also fragile, right? And because of all these things, our RBC is in great danger now. How? So first main enemy of our RBC is the spleen. Okay, and within the spleen, cords of Billroth is the main villain over here. The defected or the defective RBC will get trapped in these cords of Billroth and will be uptaken by the macrophages in it. So macrophage will eat all these defected RBCs. The second enemy is high susceptibility to the oxidative stress now. Because it is much more rigid and much more even fragile, even the less oxidative stress can cause the damage to the RBCs. So much more prone oxidative stress, susceptibility will increase. Susceptibility will increase so much, drastically much. Then next will be intravascular hemolysis. Intravascular hemolysis. Now this is not that common, but again it can still happen. This usually happen in areas where the overall lumen or diameter is so much narrowed. So in narrow lumened blood vessels, these fragile RBCs undergo a lot of tension and stress in order to pass through these structures, and because of this also there can be intravascular hemolysis, also because of chronic hypertension this can happen, but again not so much common. Now, um, being said that the intravascular hemolysis, so in this case, two different types of hemolysis are seen. Majorly it is extravascular, and in extravascular, the first and very important one is the spleen. The second one after spleen is the liver. Same, okay. These defective RBCs will get trapped within the liver, okay, sinusoidal spaces, and again it will be uptaken by the macrophages of the liver. The next structure can be um, the lymphoid system. Spleen itself is a lymphoid organ, but again other areas, lymphoids, can also take part in it. And intravascular hemolysis, again because of chronic hypertension and neuroillumined blood vessel, this can again cause precipitation of intravascular hemolysis. Again, it is minor. So overall, hemolysis is of two different types in HS: extravascular and intravascular. About 80 to 90% cases it is extravascular, and about 20 to 10% it is intravascular. Intravascular we already discussed, and the rest of the other conditions are extravascular. Okay, now let's see what is actually happening with the HSRBC. Now the HSRBC, or hereditary spherocytosis RBC cell, will have increased amount of MCHC, I mean corpuscular hemoglobin concentration within the RBCs. And how much it will be? It will be more than 36 gram per deciliter. Now, how this happened? This happened because of concentration of hemoglobin. Wow, what a thing I just said. Now this concentration actually happened because of, now this is due to concentration of hemoglobin, right? Concentration of hemoglobin, and this actually happened because of intracellular dehydration. Okay, this was happening due to intracellular dehydration. And how this intracellular dehydration occurs? So, first thing, there was loss of membrane lipid asymmetry, that is a defective portion of RBCs is lost. So loss of membrane lipid bilayer, it will take some fluid out of the cell. It will cause some removal of fluid as well, fluid lost from the cell. So main mechanism. And also very important one, apart from this one, apart from fluid lost in the form of vesiculation, that is the increased cation leak. Remember band 3 chloride and bicarb exchanger. Now because of this, and due to increased sodium permeability, so there is increased amount of permeability due to the sodium, and because of this potassium loss exceeds. So potassium loss exceeds. Normally the potassium is inside, sodium is outside, right? So whenever the cell takes up the energy, these exchange happen, and ultimately ATP pump corrects it, that is, it pumps potassium again inside and sodium outside. Now, because of it, as already there is huge amount of um, sodium permeability is increased, right? And also the potassium, which should be inside this cell, starts to get leaking outside, and the speed of correction is not that fast, right? Which means that, okay, let's try to understand it is in much more clearer. So we just said what? We just said if it is a cell, okay, and normally the sodium is outside and potassium is inside, and this is our channel. Also, there was channel for band 3, right? So because of the defective band 3, it was pumping that is the Cl and the bicarb. So band 3, which was ultimately pumping sodium, mainly the Cl and the HCO3, and we know that the Na always follows Cl and the Cl always follow Na. So which means that if there will be Cl, more and more sodium will be outside, right? And because of some intracellular mechanism, if even the little bit of amount of sodium is pumped in, it will be pumped out ultimately in very fast mechanism, right? And this ATP pump, okay, it will start to correct itself, right? So it will pump sodium outside and potassium inside. However, in this condition there is increased amount of cation leak, so huge amount of potassium is lost, okay. So overall, this potassium, which must be inside, which is not in this case, huge amount of potassium is also outside, so overall intracellular salt concentration decreases. So overall intracellular salt concentration decreases, and because of this, water follow the area where there's more and more amount of salt. So overall water will start to get accumulate outside, okay, rather than being inside of the cell. So because of this, the cell will dehydrate, or first of all, so H2O follows. Now usually we know that the H2O usually follow the sodium. However, in this case, yes, there is that is the outside of the cell, there is sodium, there is potassium, chloride and bicarb. In this case, the H, that is the K plus concentration outside this cell is so much, and in this case the H2O follows potassium more than the sodium, okay. Usually it is opposite, water follows the sodium, but in this case, because potassium loss is much more higher, okay. So yeah, so we are done with this. Now ultimately there's more and more solute outside, water followed it, leading to loss of water intracellularly. So ultimately, concentration. So inside is the hemoglobin, right? Inside is the hemoglobin. It will start to get concentrated. Now because of this, cell will shrink and hemoglobin will get concentrated. Now because of it, there will be increased chance of reactive oxygen species damage, and ultimately it will lead to hemolysis. hemolysis. And because of overall that is the hemoglobin concentration, overall concentration to the blood will also increase. So blood viscosity will also increase. Now, so we just said that there was cell dehydration. Now, why I'm actually explaining you this concept, because this concept is very very important. Okay, so there was cell dehydration, then because of that there was hemoglobin intracellular, of course, hemoglobin concentration happen, and there was increased amount of ROS, reactive oxygen species, damage. And because of this damage, more and more amount of RBC will get damaged, so increased amount of hemolysis will happen. And also there was overall blood viscosity will also increase. Viscosity. Now we just said that because of because of the vascularization, already the cell is spherically, the cell is spherical, it is rigid and less flexible. Now any attempt to draw more fluid in it, okay, the cell is dehydrated. Okay, the cell is dehydrated, it is small, it is spherical, it is rigid and less flexible. So any attempt to draw more water inside, the cell is rigid, okay, it is fragile, okay, it is spherical. Now anyhow, forcefully, if we try to push water inside, it will burst. Okay, so any attempt to draw more fluid in HSRBC, that is, let's say our RBC, this is our RBC, it was kept in a hypotonic condition. Okay, so because of the hypotonic condition, the H2O will come inside of this RBC, and because of this, cell swelling will causes the rupture much more faster than in normal conditions. So in this case, the osmosis will be a bitch. Okay, there will be hemolysis because of this hypotonic condition which can be created by any different means, doesn't matter. Okay, it will cause hemolysis much more faster. Hemolysis will be much more faster than it occur in normal patients. Okay, normal patient without HS. So we just learned different types of mechanism of how damage occurs, right? So now let's see about the clinical features, clinical case, clinical scenario, and everything. Clinical features. So first of all, we must remember the triangle. Okay, now this is a triangle for HS, that is the triad. Now what is this triad about? There will be anemia, there was anemia, there was splenomegaly. How I will tell you. Then there will be jaundice. Okay, so first of all, there was huge amount of hemolysis, right? Now this hemolysis will ultimately causes less amount of RBCs, right? So less amount of RBCs will lead to anemia. Okay, so there will be features of anemia in it. So pallor will be seen. There can be tiredness, there can be shortness of breath, there can be also tachycardia. Now, because of the damage to the RBCs, right, indirect amount of bilirubin will increase. So indirect bilirubin will increase. Indirect bilirubin will increase, which will get deposited into the skin. There can be icterus, jaundice, can be seen yellowing of the skin. Also, there will be, now because of the same indirect bilirubin, deposition can be there. There can be what we say is that the pigmented gallstones formation will increase. Pigmented gallstone formation and its occurrence will increase. Okay. Now also for the splenomegaly, more and more amount of defected RBC will get trapped in the spleen, and overall the size will increase, not at one time. When this disease persists for a very long period of time, the overall spleen size will increase. So, and we know that the spleen and the liver is so much closely related. So splenomegaly not always happen alone. So there is hepatosplenomegaly. Hepatosplenomegaly happens first. The splenomegaly happens first, and then in the later scenarios, liver can also be affected. Okay. So we just said that the overall RBCs. So RBCs amount is less now. So body will try to compensate, right? Because of hemolysis, RBCs overall number was less. So body will try to compensate it, right? How? It will go to the kidney. The kidney will sense that there's overall all these symptoms of pallor, tiredness, SOB, increased heart rate, jaundice, and so, and body will try to produce more and more amount of erythropoietin. Okay, so erythropoietin will increase in this case, and because of it, more and more amount of immature or semi-mature forms of RBC will come into the bloodstream, which we can see in the blood smear, right? So because the level of maturity of RBCs is not there, overall functioning get hindered. Okay, and also we know that whenever the erythropoiesis happen, it will totally depends upon how severe the condition is, and while at the time of this erythropoiesis which happens in the body, it will depend, okay, on several factors how mature the RBCs will be. Okay, so for the erythropoiesis, there are different factors responsible for the overall maturity. Factors responsible for maturity of RBCs. Okay. Mostly the environment factor, that is overall the diet, which must be rich in iron, folic acid, B12. Okay. Overall stress and other multiple factors which are involved. Okay, so let's say our patient is a female, a rural female which is not so much educated. She have this disease, and In the chronic level, there is erythropoiesis because of an increased amount of erythropoietin. However, the diet sucks so bad. Let's say the patient is not having enough amount of all these things. So more huge and hefty amount of immature RBC will be uh, in the bloodstream, right? Now let's say there's a kid, because this is not a autosomal dominant condition. A kid can also be affected, right? So one differential condition is that a child can be infected with parvovirus. Okay, so with parvovirus infection, it causes the aplastic crisis. Aplastic crisis, and because of this parvovirus, there's decreased amount of bone marrow. So there's overall bone marrow suppression, right? There's again splenomegaly, and again hemolysis, which will cause the jaundice. So all the same things, and this also decreases the RBC so much. Body will again try to increase the amount of RBC by the erythropoietin, but because of all these given features, it will fail. So overall, a more and more amount of immature RBCs will be there in the circulation. Okay, now let's see about the differential diagnosis. Differential diagnosis. So we just said that it is a hereditary spherocytosis, right? In the very first slide, I just mentioned about it. Now, the name was hereditary spherocytosis, so which means that is it possible that there is also non-hereditary? Yes, it is possible. It is called as acquired spherocytosis. Okay. So, first thing, that acquired spherocytosis, right? And this can be due to so acquired means that the patient will acquire it in the coming life. So autoimmune hemolytic anemia because of antibodies. Then there can be DIC, disseminated intravascular coagulation, thrombotic thrombocytopenic purpura, TTPs can be there. Then there can be hemolytic uremic syndrome, HUS can be there. It is also seen that AS is also seen in some cases of infection or toxins of some bacteria, specifically Clostridium perfringens. Whenever a patient have been infected with the toxins of perfringens, there is a high chance that a patient will show spherocytes in the circulation, and it is a type of acquired spherocytosis. Okay, then there is G6PD deficiency. It will also cause the same thing, and it will show the bite cells. We'll talk about G6PD deficiency some other time, right? Okay, and these bite cells are also called as the degmacytes. Then there can be sickle cell disease, and where the sickling, that is RBC, becomes somewhat moon shaped. Okay, crescent moon. Then there can be thalassemia, and in thalassemia, podocytes, that is the target cell. So overall cell looks somewhat like this, target cell. We'll discuss all these different types of pathologies in some other video lectures. This lecture is already so much lengthy now. And then there can be hereditary elliptocytosis, HE, that is elliptical RBCs are seen, so which is more like this and not like crescent one. The crescent one is sickle shape. like this. Ellipsoid is the ellipsocytosis and the sickling is the for the SCD. And now let's see how to diagnose it. Now let's see how to make a diagnosis. For the diagnosis, first of all, family history will be positive. Family. Okay, here it is. So for positive family history, positive signs and symptoms and everything. History is also positive for everything. So lab values. Okay, hemoglobin itself will decrease. Okay, hematocrit will also decrease. However, the MCHC will increase, and I guess this is the only disease for the RBC's disorder in which MCHC is extremely high. So this is kind of very important thing. Also because the overall size of the RBC was less, MCV will also decrease. Okay, so MCHC, important one, remember it. Okay, also because of the erythropoiesis, reticulocytosis will increase. Reticulocytosis will be increased. However, this will happen if bone marrow is functioning normally. If bone marrow is not functioning normally, or let's say if kidney, because of some comorbidity, let's say kidney is not functioning normally, in any of this scenario, because kidney is not functioning normally, there will be less amount of erythropoietin, right? So all these two factors will again decrease the concentration of even immature RBCs, and the condition will be much more worse. Okay, then there will be indirect bilirubin concentration will increase so much. We just also said that the pigmented gallstones occurrence will increase, so we can go with the USG of right upper quadrant to check for stones. Then we can check for very important peripheral blood smear can be obtained. Blood smear will show the spherocyte. Now we also mentioned that any attempt, okay, now this was very important box, overall attempt to any movement of fluid inside the cell will causes its rupture. So because of this, we can also go for one more test, that is the OFT, osmotic fragility test will be positive. Osmotic fragility test will be positive in this case. Also the genetic test we cannot avoid, along with the membrane and the molecular structural test can also be done. Okay, and also we can check the flow cytometry. So all these things must be remembered. So OFT important, genetics important, indirect is important, MCHC is important. Yeah, one more thing. So because this is not an autoimmune condition, so one test which can help us to rule out the other autoimmune condition is the Coombs test, right? So the Coombs test will be negative. Now this will help us to rule out the other autoimmune condition, that is in this case will be autoimmune hemolytic anemia. So Coombs test, right? Okay, and let's talk about its treatment option. Regarding the treatment, okay, so again, being genetic disorder, there is no cure of it, only we can give the supportive management. Okay, that is give blood transfusion, and note, match everything, check for any kind of infection before blood transfusion. Okay, then there can be cholecystectomy if there is gallstones, and very important, okay, very important, that is the splenectomy. Splenectomy must be done because this is the main organ which was causing the disease, not causing the disease, which was actually abbreviating and causes the increased amount of severity of the condition. However, even after doing the splenectomy, there is no cure. It will only decrease the severity. So splenectomy will only decrease the severity. However, the RBC will still live up to like 10 or 20 days. Maybe the cell will live up to 30 days. Okay, but again, this is not the treatment option. Okay, then if there is problem with some erythropoietin formation, we can give erythropoietin externally, then supplementation, okay, with iron, folic acid, B12, B12, iron can be supplemented so as to increase the chance of having at least mature RBCs. I know these mature RBCs will end up having defective proteins, will again cause the hemolysis, but it will again decrease the severity. So no treatment option, right? Okay, now let's see some images. Okay, do I have some images? Yes, I have some images. Okay, these are two conditions: how normal levels of hemoglobin and cellular volume is seen in the normal condition, where in case of HS, this is the normal, this is the HS. Overall shape size decreases and the MCHC will increase. RBC will look somewhat like this, like this. However, there is no chance that all of these cells will look similar, but again, majority of them will have a spheroidal shape. Okay, now let's see ellipsoid. Okay, so this is the condition of hereditary ellipsoid cytosis. Okay, very nicely we can appreciate the different types of ellipsoid shape RBCs, right? All of them. Okay, next. These are the different pictures just to make you familiar how the other different conditions look like. So there are bite cells, right? It look like somebody ate this part. So bite cells, which is much more common in G6PD deficiency. So this was for the G6PD deficiency, and this is a bite cell. byte cell. Okay, for the next picture, remember there are different other morphology of RBCs. Okay, different types: ellipsoids, macrocyte, codocyte. Okay, you can appreciate this codocyte, how it looks like. It looks somewhat like there's a target. Okay, so target cell, which is again seen in case of thalassemia. We will discuss thalassemia in some other lecture. Then there can be hypotonic, eccentrocytic, pycnocyte, and there are different many types. These are your agglutination condition, agglutination condition, in which the RBCs clumps together. RBCs clump together. We'll discuss all of them in some other lecture. This lecture is already so much lengthy now. And probably the last slide. Okay, again, just for help, not so much important related to the our lecture, how the different morphology of RBC looks like. So Howell Jolly, basophilic stippling, Cabot ring, we'll discuss every single thing separately. So yeah, this is the end of HS. Okay guys, thank you for watching.